Hello everyone, a very good evening. I am Dr. Sanjana Chavan from the Indian Dental Association and I welcome you to today's webinar on the functional occlusion game changer in your dental practice. It's my pleasure to introduce you to our esteemed speaker, Dr. Rohan Bandi, a prosthodontist and the founder of World Smiles Dental Center, Mumbai. With over 15 years of clinical experience, he specializes in full mouth rehabilitation, functional occlusion, TMJ management, and orofacial pain. He has served as ex-chief dentist at Wockhardt Hospital and is a consultant across multiple clinics in Mumbai and has several research publications to his credit. So let's all welcome Dr. Rohan Bandi. Over to you, Doc.
Hello everyone. Good evening. Am I audible to you all?
Yes, we are. You're audible, sir. You can
Okay,
proceed.
perfect. Uh, is my screen also audible to you? Plus my video.
Yes.
All right, perfect. So, welcome everyone. On a Monday evening at about 8 p.m. in the evening. Uh, I'm so happy to have you all here. From your busy schedule, you all have made time. This shows two things. Okay, number one, that you realize the importance occlusion holds in your dental practice, or number two is that you know very little about occlusion, or you would like to learn more. But whether you're from this part or this part, be rest assured, today's webinar is going to change the way you uh, look at dentistry and the way you look at your patients from tomorrow morning. So let's begin. Uh, so I would like to start with a saying to say the capacity to learn is a gift. The ability to learn is a skill, and the willingness to learn is a choice. So I'm glad you all have made the right choice to 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 come here on a busy Monday, on a busy Monday night, and to learn. Okay, so so occlusion actually in itself is such a vast topic. We can get a separate subject on occlusion, and if you go to completely understand occlusion, 2 to 3 days may fall short. So what is the goal of our today's webinar? Well, what I have done is, uh, with lots of efforts, I have tried to bring the most important principles of occlusion, which will do three things. It will create awareness in your mind. So from tomorrow, when you look at patients and their teeth and the occlusion, there will be, an, be a new perspective to it. Number two is to create an awakening. What is the awakening? That to do what harm you can do to a patient and the patient's masticatory system if you do not understand occlusion, right? And the most important is the curiosity to learn how does it work, how does the occlusion function, right? So always remember the Hippocratic oath that we took, right? What was the oath? One of the most important points is, if you cannot do something good, please do no harm. And trust me, this oath serves so much purpose in dentistry also. You will realize this today during the course of the webinar, that when we lack knowledge about something, the amount of damage and harm that we can do to the patient knowingly or unknowingly. So keeping this in mind, let's take it forward. So what is occlusion? Is it the angles classification that we learn it our orthodontic textbooks, which actually related the molar which actually related the molar relationship? That's a class 1 of the first molar. Is this what comes to your mind when you think about occlusion? Or is it decided by the canine? That is the way the canines meet. That is the upper and the lower canines meeting. Is this what governs occlusion? Or is it by the anterior teeth forming the anterior guidance in class 1, class 2 div 1, class 2 div 2, or class 3? Hmm. Well, or it could be the bony landmarks and the facial profile of the patient. Does this come to your mind when you think about occlusion? Well, let's see. So, what is occlusion? Uh, is it a combination of all these things what we have learned? Hmm, not really. Then, so this is how the teeth, interrelate. I would repeat, interrelate, also called as maximum intercuspation. But this is not occlusion. Then, so to answer what is occlusion, we must first ask the question, where does it start, right? So the occlusion starts somewhere in front of your ears here. This region is called the temporomandibular joints. So today I'm not here to teach you, Netter's anatomy or Gray's anatomy. Okay, I just want you to know these four basic terms in temporomandibular joint. That is, there are two bones. One is the articular surface, and one is the condyle. Okay. While I'm talking, I also hope that you all can see me there in the side window. Can just somebody tell me that, like along with the PowerPoint, can you see my face and my hands, Mr. Varzi? Okay, 1 minute. Can somebody tell me here? Orange. Okay. So, okay, I presume you all can see me plus the presentation. So I'm taking it forward from here. Okay. So right. So where were we? We need to understand we have got the glenoid fossa and the condyles, and there is a disc in between. This is basically attached by some ligaments and some muscles. Okay, so where does it start? Where does occlusion start? So it starts with 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 the socket in the base. This is the socket, right? And glenoid fossa. Then we need to add the lever arm, which is going to open and close, right? That is the mandible there here. Uh, this is the this is the lever arm that we have added. Okay, so now temporomandibular joint. Now this is going to open on a fixed axis. Now, if this continues to actually open on a fixed axis, it's going to compress our airway, right? So we need to make this axis movable. Okay, so we need to make the fulcrum movable, so it when it is opening, it can also slide forward. So for the first 20 millimeters of your opening, there is only a hinge axis movement, right? Beyond the 20 millimeters, the mandible translates down, which makes the mandible come forward. So when you open further, it's not going to compress your airway now. Then we need to limit these movements. So this is done by attaching some ligaments. These ligaments are the temporomandibular ligament, which is the most important ligament. Now, this all structure needs to be kept enclosed within a capsule, which is the capsule surrounding the TMJ. Now, now to move the jaw, you need to add something, right? And what are those? You need to add some muscles. They are the muscles of mastication. Now, the muscles of mastications can be of two types, right? One is which help in opening the jaw. They are known as the depressor muscles, or the one which help in closing the jaw. They are known as the elevator muscles, right? So these are the four important muscles that you need to know: temporalis, masseter, and the pterygoids. This is the way the masticatory musculatures play a role in occlusion. That is, in moving the condyles. Okay. Now the last thing that fits into this design is, that's right, the teeth. So the teeth are not the first thing when you talk about occlusion. They are the last thing that comes into the picture. But as contrary to what we have learned and what we see, the first thing we see, the first thing we look at, that is the teeth. What we need to understand is that the teeth need to go and fit into a pre-established maxillomandibular relationship. That relationship is formed by a bone against a bone, fitting precisely into one another, enclosed in some ligaments and controlled by muscles. So this this relation doesn't involve teeth. The teeth come and fit into this relationship. So there is no such thing as a perfect occlusion without knowing how the TMJs are, the displaced TMJ. That means both the position and the condition of the TM joint must be considered to in relation to the maximum intercuspation of the teeth, right? So you need to remember, you know, intercuspation is static. Intercuspation is static. Occlusion is dynamic, right? So, keeping this in mind, let's take it forward. I hope you all are there with me till now, right? So, how does this dynamic movement take place? Well, it occurs in the terminal hinge axis. Now, when I talk about terminal hinge axis, I like to relate to it with a simple door hinge. Now try to imagine there is a hinge in your door of the house, or maybe the wardrobe, right? It is just going to open and close, correct? Now, what happens? That's how your mandible is actually opening and closing in the terminal hinge axis. There is no other place that the mandible can go when it is there in the initial 20 millimeters of your opening. So, what happens when you try to stretch or pull the door with with the hinge joints? Any guesses? Well, either your hinge is going to break, or the screw is going to become loose, or your door will fall off, right? That is what actually happens in the joints. But when you want to see the see the masticatory system, I would like to see it like a 32-piece jigsaw puzzle. Okay, have you seen the puzzles of the kid? If where each and every member has got a specific shape and a specific position. Now just try to imagine there is a puzzle with 32 members there in a box. If you change the position or shape of even one member of the puzzle, will the puzzle fit in the box? If your answer is no, then we are on the same page up till now, right? So this is the puzzle given to us by God, given in the patient's mouth. Now the problem starts when we don't understand this puzzle and we do something in the mouth, or the patient eventually gets something done in the mouth, which changes the relation of the teeth in the terms of shape or the position. Now that same hinge axis, what was there, cannot close because it's being stretched and pulled, right? So we need to remember, when bone and muscle is there at war, the muscles never lose. This quote was given by the famous doctor Harry Stitcher. And when teeth and muscle are there at war, okay, still the muscles never lose. So who loses? This quote was given by the legendary Dr. Peter E. Dawson. So when teeth and muscle are there at war, what happens? The cost is borne by the teeth, and that is a very painful and expensive cost in terms of occlusal disease, right? So we are prone to many gross negligence and mistakes if our understanding of occlusion is solely limited to the occlusal contacts. So let's try to understand what is occlusal disease. Now, disease in the medical terms means that means there is some loss of form or function of any part of the body, of the human body. When you talk about occlusal disease, it's a loss of form or function of the masticatory system altogether. So remember, your eyes don't see what your mind doesn't know, right? There are many things that you are seeing across, but you do not give it the importance because your mind doesn't know, or you tend to neglect to it. So occlusal disease, this is something routinely that we see in our practice. Thinking, okay, this is part of a physiologic process. Well, let's think again. So what are the types of occlusal diseases? Before knowing the different types, okay, let us know the signs of disease always precede symptom. This is the law of medicine, right? And the structural damage is always progressive. That means the disease is not self-limiting, especially in terms of occlusal disease. If you do not diagnose and intercept it at the right time, it is going to lead to a cascading cycle which makes it progressively more and more damaging for the patient, making it more costlier for the patient and more difficult to treat, right? So one of them is attrition. What is attrition? It is the wear due to tooth friction, right? But just imagine Uh, Tooth, as we know, is made up of the outer layer, that is the enamel. All right. Now, enamel, as we know, is one of the strongest substance in the human body. It is even stronger than bones. Uh, you know, it was meant to survive a lifetime of of a person. In fact, to say that a tooth can survive millions of years, because because in the fossils of the animals and the humans, we have found that tooth have been found in the perfect shape. So why would a strongest substance in the human body start to wear? It is definitely not going to be physiological, right? So let's look at this case. This is one of the case which comes to your clinic. You see occlusal wear facet. The patient comes to you with a complaint that, doc, there is there is a hole in my tooth where the food gets stuck, and it's very annoying for me. Can you please help me with it? Well, you look at it and you're like, fine, okay, let me just take a look. Yes, I do see a saucer shape, depression, which I can restore and give the patient some relief. Hmm. Uh, so, 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 so you take your composite and you fill up the hole. You check it in bite. You make sure that the occlusion paper or the mark is not coming on the filling, and you are happy. Then what happens? The patient comes back to you after maybe a few months, or maybe a few days, or maybe after a couple of years. He says, doc, the filling that you did came out. Now you have two options. You think, okay, I can try to redo this filling like in a more better way, since I have some more knowledge and some better materials. Or okay, now this time let me try and do a cap. That's where you go completely wrong, right? Let's see out why. So one more occlusional disease is basically abrasion, which we are not going to talk about and cover today, because this is caused by a external agent, namely toothbrush and paste. Erosion. This is something important to us because they can be chemical, which is by the external, or it can be endogenous by the patient's own gastric reflux. So you can see sometimes completely destroyed the dentition, especially the palatal side of the upper anteriors and the posteriors, when a patient has got a strong gastric reflux. Okay, so a chemical erosion can also cause severe occlusal disease, right? One term that we have read about is abfraction. But what do we do when we see abfractions? It is caused by occlusal overload. We do a composite classify there without trying to see, along with the abfraction, if there is some attritional wear there also. So though you have covered up the class by restoration, which was a wedge shaped defect, sometimes you find after a few months that is out again, because you fail to address the cause of the disease. Why did the abfraction occur? Because the tooth was under load, right? Now, let's look at a case where you see attritional wear in the anterior teeth. So we have these two ladies, two cases who came to us saying that they are not so happy with their front teeth because they have started to wear, and they want to do something about it. So what do you think? Okay, this doesn't look to be that much of a challenging case. Uh, I have learned, nice layering techniques in my last composite course. This will take me about 1 hour's time. I can definitely layer the anterior teeth and make the patient happy. Think again. When you see anterior wear, when the patient gives you no history of a fall or, or a crack, the first place you look at is the back teeth. Okay, there could be some deflective interferences in the occlusion. Let's look at this case. When you just see the front, okay, you will feel that this case is pretty much simple to go. Now when you start looking inside, you see something at the back here, right? Okay, and you see something at the back here. Now let us see what is there. Okay, so there is an old cap which was done. Now try to remember that 32 piece jigsaw puzzle that I showed you there in the beginning. Do you think this cap was the exact same, replica or a similar shape and size as the original tooth? I don't think so. Also, this tooth was removed here. These teeth seem to have migrated. Now, tell me one thing. Can the hinge axis now close in the same manner as it was closing previously? No, there is going to be stretching of that hinge axis, which probably leads to the wear passage that are seen anteriorly as well as posteriorly. Can you see this here, molar? This is exactly below this tooth here. So there is something coming in the way which is not letting the joint function the way it is, leading to this chip that we see in the front. So my dear friends, if you go on to jump on to doing a composite restoration for this case without diagnosing the occlusal disease and the occlusion, you are going to land up in trouble, and you will be married for the patient the rest of your life. Okay, so we need to know some other forms of occlusal diseases too. Okay, what are they? Splayed teeth. Okay, you had patients coming to you sometimes saying that, doc, I have noticed that my teeth have started to move out, uh, you know over the past few months or years. So you say, fine, okay, let me see, I think I can put them back in space by doing braces or by doing a smile makeover. Well, yes, you can put them back, but you first need to ask the question: in the absence of tongue thrusting and in the absence of any active periodontal disease, why are the teeth getting splayed? Okay, you can have completely destroyed dentitions. Now you remember, destroyed dentitions are an extreme form of occlusal disease. Now sensitive teeth. Now you may have come across cases at times where the patient says, doc, one of my tooth on biting or when I'm drinking feels extremely sensitive. You take an x-ray, you find there is no cavity. You completely examine the tooth, there is no attrition, there is no wear, but the tooth is very sensitive. It may be sore to some clenching clenching or percussion. What could be the reason? That tooth can be coming in the way of a completely harmonious functional closure, right? This, so remember, this, the what is the number one cause of tooth sensitivity is not caries. Caries is the second most important reason for sensitivity. Trauma from occlusion, that is the interference in bite, which leads to slowly soreness of the tooth, which leads to slowly attrition, is the number one reason for sensitive teeth. Sometimes they can become mobile. Also, you could have a split tooth or a fractured cusp. These are all types of occlusal disease. And finally, it's going to take a toll on the musculature, because that's where the movement is all completely happening. So we need to understand the role that a dentist plays. We are not just dentists, we are the physicians of the masticatory system. When you put yourself at this level, then you will start seeing and observing things from a different level. So, looking for signs of structural deformation while the problem is still correctable and it is, easily reversible, is the goal of studying occlusal disease. The reason I have covered occlusal disease today is not to brief you back to your theory of conservative dentistry. No, is to make you realize that before the patient comes with the symptoms, there are signs in the mouth which you, as a dentist, has got the moral, obligation to see and to correct at a early stage, so that it doesn't destroy a dentition, right? So, you can make sure the patient doesn't land up this by just getting some basic knowledge, and by seeing and completely observing what is there in the mouth. Okay, so let's not try to have such more cases. So now let's come to what is the formula for a a perfect occlusion, right? For now, okay, remember and by heart the statement: dots dots in the back, lines in the front. Okay, I will repeat once again: dots in the back, lines in the front. What do you mean by this? Don't get confused for now. Just try to keep a memory of this slide. This I will come to you come back to this slide when I'm going to show you the case of what do you mean by dots in the back and lines in the front. But this is the formula. So what is the position of the condyle which permits, interference free perfect occlusion? So finally, I want that my condyle should permit me to go in that perfect occlusion place. So what is that position called? Well, it's called centric relation. And I know, since your dental days, we have dreaded this term, right? We thought, you know, once our once our internship got over, once our fourth year got over, we no longer we no longer have to deal with it, right? But just calm down. That centric relation, what you learned in your uh, prosthetic clinicals, where you ask your patient to put the tongue on the palate and swallow, or you ask the patient to swallow and bite, is not centric relation. Okay, so what is centric relation? Don't worry, I have got you covered. Centric relation is the most natural and the most, physiological space position where the joint needs to go. So let's make it very simplified, without that GPT definition that we had to by heart and, write down 10 times, I don't know, 50 times, and then, say in the Viva. No. Let us just try try to basically understand that it is the, superior most position. Once again I repeat, superior most position of the condyle in the fossa with the disc in between. If you remember this, you have understood basically half of centric relation. Now, when this happens, the condyles can rotate, but the rotation doesn't happen on the top of the condyle. Okay, you need to remember that the glenoid fossa is not rotating at the superior surface, but it is rotating there at the medial poles. So that is the point of rotation, and that point of rotation can be pointed out on a pantograph with a pinpoint accuracy. Let's see how. So this was the GPT definition which we so didn't like to learn a lot. But okay, what we need to see here is this is the most superior position against the dementia, which is irrespective of the vertical dimension or tooth position. That means teeth have got no role to play in centric relation. And we always used to think that the teeth is what decides the centric relation. No, my dear friends. Then, not to be confused with centric occlusion. We no longer use this term. It is replaced by maximum intercuspation, right? So centric relation is not about teeth, but it is the topmost and the midmost position. Keep this in mind, and it has got needle point accuracy. So it is highly repeatable plus precise. Okay, so coming to what is the way to determine centric relation? There are a few ways, but the most effective and reliable is Dawson's bimanual palpation. Okay, so I'm just going to show you a brief, video as to how to do the Dawson's bimanual palpation. Uh, just a second, I'm just going to. Uh, uh, Let me just turn on the sound for you guys. So today we'll be learning how to guide the patient. So today we'll be learning how to guide the patient in centric relation using the Dawson's bimanual palpation. So the number one thing is when you start off with it, you first need to recline the patient to a completely supine position. Ma'am, please push yourself up the chair. Okay. What is important is that you need to be right behind the patient. You cannot do a bimanual palpation by sitting towards the side, at the 11 o'clock, 9 o'clock position. You need to be right behind at the 12 o'clock position. Okay, you need to have a direct view of the patient's mouth when you're seeing from above. Make sure that the patient's head is completely stabilized there on the chair. Plus it needs to be stabilized, against your tummy here. This is a very important part and step. Now the next step is extend his neck and chin completely upwards. Please extend your chin upwards. Okay. After that, you need to place your four fingers towards the angle of the mandible, but behind the midline. So you need to make an imaginary midline in the mandible and keep the four fingers behind it. All right. And you need to make one arc with your thumb. So you have to place the thumb towards the symphysis here, and you plus need to place your four fingers behind. Now slowly just ask the patient to open the mouth once, neck up. All right. Now make sure your fingers go behind. Just open. All right. Just be loose and relax. Wonderful. Just completely relax your jaw. Yeah. Okay. I'm just gonna do a open close. Okay. You don't do. I'm going to slowly guide you.
Yeah. Where was the first touch, ma'am?
Yeah.
Somewhere at the
This
back
side.
there?
Yeah.
Okay. 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 I'm going to do it again. Okay. We stop at the first touch. Right? Yeah. That's the first touch. There at the back here. Yeah. Now you please bite further. Yeah. Clench. Yeah. You could feel your teeth sliding onto one another.
Yes.
Okay. I'm just going to do this exercise again with you. Can you please open? Yeah. That's the first touch there. Yeah. Now please slide further. Yeah. You could feel the teeth sliding onto one
Yes.
another.
Yeah.
Okay, so I hope you all could see this video and completely listen to the audio also. So you all saw there was a hit and then a slide. Now, why was it there? This is the same case. This is a patient whose orthodontic treatment has been done. She has the best perfect occlusion, that is the angles class 1 relation. Now you see this is her maximum intercuspation. You think there is nothing wrong with the occlusion, right? Beautiful occlusion. Okay, how can something be wrong here? Now let's look behind. Can you see the wear on the first molars here in the upper arch? And can you see the wear there on the first molars here, right? So, you know, what have we learned? That the signs precede the symptoms, right? So, though the though the angles classification is right, but occlusion is not angles classification. It is dynamic. It is dynamic, and there is a hinge axis in which these teeth have to close, and when it doesn't closes, it causes this wear here. Okay, so now what we have learned, the Dawson's bimanual palpation, this actually needs training and practice, but the most important point there in guiding is the position of your fingers, right? That's how it needs to be positioned. The thumb is needs to be on the symphysis and the forefingers behind the midline. Now remember, you are not pushing the mandible, you are only and only allowing it to go, guiding it in the most natural position where it should go, but it cannot go. Why it cannot go is because there is something coming in the way, right? So the key at this point of maneuvering is delicacy. So Dawson calls it something called as romancing the mandible, where you just play with the mandible. This comes with time, and it comes with practicing in multiple patients that you see, not just one. Make sure that you do it in each and every patient that comes to your clinic. So while doing it, make sure the teeth do not touch. Okay. Now, no matter the way the condyle seat, you cannot say by touch, alone whether the condyles are in centric. So you need to do something called as the load testing. That is, you need to load test to actually verify whether my centric relation is right or wrong. So, how do you do that? Okay, let's look at this video where we are going to
So after we have guided the patient in bimanual palpation, so the next step comes is to verify that the position that we have got is correct or not. That is, the centric relation position needs to be verified. That is done by load testing the mandible. So for that, we have also made something called as a customized anterior deprogrammer. I'm just going to show you the way we are going to place it. So we have made it on the patient's cast and models that we had taken. Uh, this is after we have placed. We will guide the patient in centric again, and then we will verify the pinpoint accuracy of the centric relation. So as we are already aware that the centric relation is a continuously repeatable position with pinpoint accuracy. So we need to mark the pinpoint, and we need to verify it. That can be done by only if we make a customized anterior deprogrammer. So I'm going to now guide the patient once. Okay, just be loose and relax. Okay, we take a sharp pencil and we mark the uh, edges of the teeth of the lower anterior incisors that are there. Jaw, can you keep the chin up? It needs to close in the same repeatable position. Okay. How do you verify the position is by taking the pencil again and in making sure that the marking is coming on the same place where you had marked it previously. If repeatedly the pencil marks at the same point, that means you have got a pinpoint contact in the centric relation. Now to verify, we have to do a load testing of the jaw. Is there any pain in the joints here?
No.
Start. Open bigger. So we have to apply a nice thick layer on both the sides. Don't cover the anterior teeth because you want to check and verify your bite. Just leave loose. Okay. So we just maintain the bite there. You need to maintain the fingers support there. Then so that the mandible doesn't slide. Then you notice the point that is there, it's still at the same point. Okay, and you can take a pencil just to verify the point again. If it's marking at the very same point like it is now, this is called a pinpoint. This is called as needle point accuracy of the centric relation.
So I hope that you all were, able to at least get the gist of how a centric, centric relation is first guided and then recorded and then verified. So the verification is the key here. Okay, if you don't verify it by a pinpoint contact in the anterior deprogrammer and by load testing the mandible, you cannot confirm uh, whether the mandible is in centric relation. So this is the same case that I showed you. So now this is the point here, right? This is the pencil mark that I had made. Now, when the mandible can completely, repeatedly close at the same point, that makes sure that means that is the most natural physiologic place where the condyles want to go. Okay, so what we did in the load testing is to verify it. So we are applying pressure towards the joint upwards. Now load testing is a common philosophy by the orthopedic surgeons. They do it for the shoulder joint, for the hip joint, for the elbow joint, but we as dentists, or rather the the physicians of the masticatory system, do not do it for the TM joint because we have not been trained. Exactly. So today I'm there here to tell you about it. Okay. So now, what do you do with those bite records that you have taken? You have to mount it. Okay, why do you mount it? Just to show it on the social media? No. You take the Facebook records, and then uh, what do you do is this. Okay, let's just take a look at this video. That's that that's how your cast which are mounted in centric relation look like. Now if you will see here that the teeth are not contacting. Why they are not contacting? Because there is a contact somewhere else. Okay, where is the contact? That you will come to know now here. When I will open the articulator, the semi-adjustable articulator, can you see at the back here? We ha- we have marked this in the we have marked this in paper. That's where on both the sides the teeth are contacting, right? So that is exactly what is taking place in the patient's mouth. So now if you see here, okay, you can nicely see that the points are here, and you can see the wear facets that are there in the model. So this is the sign of the occlusal disease, right? So you do not want it to progress further. So if there is something which you can do there minimalistically, which can remove the interference, which can prevent the patient from a future problems of a destroyed dentition, then you should do it, right? So mounted cast on the semi adjustable articulator make it possible for like you to see that what is the way the teeth will relate, and what is the best treatment goal for the patient. Whether you need to extrude the the teeth by doing ortho, or you need to do some caps and some full mouth rehabilitation, or you can do it by some simple occlusal equilibration, right? So the purpose of this full therapy that we are doing is what? Is peaceful musculature. Masticatory musculature needs to be comfortable and peaceful. Why? Because they are the most dominant determinant of what? Centric relation. We cannot keep teeth in a stable position. That means the teeth cannot remain in maximum intercuspation where the muscles do not want them to be, right? So peaceful musculature is the goal. When there is some incoordination of the masticatory musculature, it leads to occlusal muscle pain. Sometimes patients complain of pain around the middle ear, around the ear. Sometimes there is referred pain in the head. Many of patients have been misdiagnosed with migraine pain, or they have been confused with the classical MPDS pain. But if the signs are there in the bite, it is actually occlusal muscle pain. So TMD is a broader pain, and the commonest cause of TMD is occlusal muscle pain. Okay, so keeping this in mind, okay, I'm going to basically I'm going to show to you some cases, some absolutely clinically relevant cases, the way we have treated them and the complaints they have come with. So this patient comes to us with pain in 3-7, and pain is severe, excruciating pain. And on asking further, she also said that she has got some gaps in the teeth which have started to form. So what do? You first take the X-ray, you see one old crown, you see, oh God, this is a badly done, root canal treatment. It is short. So patient is in so much excruciating pain that you want to give the patient some relief. You have two options. You can extract the tooth, or you can extract, or you can do a re-root canal, or there is a third option, that is to check to check the occlusion. Okay, now let's go and completely examine the patient, right? So this is a smile, and if you observe closely, we see some wear in the front tooth. Now, she has no history of fall. She is a young lady, there in her late 30s. Why would she show so much of wear in the front tooth? Well, let's look in further. She had spaces in the lower teeth and she didn't like the spaces. So, what is the best way to close the places? Well, the cheapest way is tartar, right? So she had tartar and she was reluctant to go to a dentist before and get it cleaned because she was afraid that the spaces will become more and more. So now you've started to see the different signs, right? Now this is the bite. The bite looks absolutely fine to you. Let's look at the occlusal view. Nothing wrong here except for some few wares. Let's look down. This is what you see. Trust me, we did not do any re-root canal for this tooth. We did not remove the tooth. We did not extract the tooth. What did we do? We just removed the old crown and we did something called as occlusal, equilibration followed by treatment for the anterior teeth. So this is a chair side anterior deprogrammer prepared in composite. There is spot bonding and it acts like an anterior deprogrammer. So I record this complete relation and I send it to the lab for a mock-up. This is the mock-up we have transferred to the mouth. Can you see the teeth are now contacting in the front? Yes, we do some minimal preps. So we prepare the patient for some front six teeth crowns and lower front teeth anteriors. These are the preps. Also at the same time, we are replacing the lower last tooth, and we have done some occlusal, equilibration. So this is the final restorations. Now these restorations are in the right relation in the dynamic occlusion, right? That is, they are in complete harmony with the patient's TM joints. So I can be rest assured that the way the natural teeth had chipped, my restorations made in lithium disilicate last will will actually last the test of time. Okay, and these are the contacts seen in the front teeth, and these are the contacts seen in the front teeth and the back teeth there here, and this is the crown that we have replaced. This is a mirror image, so you need to check that. So from this, we have this where she's happy and the spaces are closed. But the most important reason is that she is happy that her pain has gone without doing a re-root canal, without doing an extraction, only by doing occlusal therapy, by doing occlusal treatment. Okay, so you have to remember muscle response to occlusal, interference. It can lead to hyperactivity in the muscles, and that can make the tooth extremely sore and sensitive. So do not jump in doing root canals and re-root canals, my dear friends. Okay, you need to understand the term known as occlusal muscle disorder. That is it is a disease or a disorder caused because of the occlusion not in harmony with the muscles. Okay, so now let's look at something which we all commonly give. These are, well, night guards. No, please, these are not night guards. Do not give them to your patients to wear in the night or when your patient is grinding or chipping his tooth. These are actually soft spots guards. They do not help the patient in any what way. Okay, so I cannot go in deep about splint and mouth guard, but it is just to create an awareness in your mind. So let us look at couple of more cases. So this case came to us with food lodgement and sensitivity at back, at at the posterior teeth, right? So when we examine the patient, we see some wear in the teeth. Yes, this is the wear that we see. Now, what makes it is that this patient, for his sensitivity, was using sensitivity toothpaste, and he had got the fillings done there multiple times. Still they were getting dislodged. There was a gap in between the teeth which was forming, which was causing the food lodgement, which was not there earlier. So what was wrong? Okay, these are the signs of the occlusal disease that are there. So please don't try to do fillings in this case, don't try to do caps in this case just to relieve the patient problem. You will do more harm to the patient than good, and the patient will not come back to you, or the patient will come back to you and then he will never come back to you, right? So you need to keep a holistic approach, and you need to look at it in terms of the relation of the condyles with the maximum biting. So this is the way we had done the digital design for this patient. These were the temporaries where we verified everything. These were the permanent teeth in occlusion. The shade is a bit off to my liking, but the patient was very happy. Now these are the beautiful basically restorations that are there. Now what makes it beautiful is not the shape, it is not the color, okay, it is not the photograph, okay. uh, it may be beautiful at the time of placement, it may look beautiful in the photos, but what really makes what makes a restoration or a process is beautiful is if it is going to last the test of time. Where, if you remember, there was a formula for perfected occlusion. Do you remember? I told you dots in the back and lines in the front. If you cannot achieve this when you're doing your rehabilitations, then, my dear friends, those beautiful pictures are just for social media and they are not going to go. So this is the photo which was there. Now I'm going to show you the same in the patient's mouth. So you see, there are dots in the back and there are lines in the front. That is, the static occlusion are the dots, and the dynamic occlusion, they are the lines. So you see dots in front and back. That is, the centric relation is in maximum intercuspation, and you see the lines in the front. There are no lines in the back. Now to explain you the way it is done is not possible in today's 1 hour webinar. It will take me 2 full days of teaching to show you the way it is done, and why do we have lines in the front. But the lines basically signify that the lateral movements or the excursive movements have got no damn you know uh, you know uh, you know you can say detrimental effects on the posterior teeth, right? This is the photos what you will see by, like, most doctors showing you that they have got the perfect canine guidance. Now you can see this in the photo, but very few clinicians are going to show you this. This is what perfect occlusion is there about. All right, this is in the lateral excursion. So from this we have this, from this we have this. These are in complete harmony with the patient's face and the musculature. So you see the reverse smile line cause of the attrition that has been corrected. Patient is happy, patient sensitivity is gone, we are happy. We have just done a 2 year follow-up for this patient. He is doing absolutely fine. So what I want to tell you in end is basically how do you check occlusion? You need a dry feel and you need some articulating papers and holders, and you need to verify the centric and the eccentric movements, right? For that you need some articulating paper, right? This is the articulating paper that you should use, right? My dear friends, this is not a articulating paper. This is a D, it is a D articulating paper. It is not, it is going to completely deocclude the tooth. Why? Because this thickness is more than two, greater than 200 microns. To check occlusion you need something lesser than 40 microns, or at times for gross, or for gross changes we need approximately 100 microns. So a simple carbon paper is approximately 100 microns. And but what you should focus is the Bosch 40 microns articulating paper in blue and red. Blue is to be checked for for the static, and the red is checked for the excursive movements. You sometimes need the 12 microns there also, that is called the sim stock, especially when you're doing implant prosthesis. Okay, now discussing implant occlusion, and this is not the scope of today's lecture. Sometimes the contacts are tight, so for that you need to pass the paper there in the contacts. So okay, now let us look at couple of one two cases before we end our today's session. I think we can exceed by about 5 minutes more, uh, since we started late. So this is one case of a failed full mouth rehab with a ceramic chip. So you see, the patient had got her full mouth rehab done of the upper jaw, but she was not in comfort. She had discomfort, she had food lodgement, and she had pain. Now, when you examine, things don't look so bad and the occlusion seems fine. But let us look here. Can you see the chip at the back here? Why is the ceramic chipping? Ceramic should not chip if it is functioning in complete harmony. And you see, can you see the wear facets here and the gaps forming in this tooth, right? So we decide to remove the crowns. We do a full mouth rehab for this patient. This is the pre-op. This is the post-op. Beautiful looking restorations in the camera, right? But are they beautiful? The real beauty is there in the function. Because if it is beautiful for a few days, few weeks, few months, it will not, and it's not beautiful after that. What's the point? So let us look. This is the before. This is the after. This is the side views. Okay. This is the occlusion. This is the occlusal view of the upper, occlusal of the lower, and what makes it most beautiful is this lovely. There are dots at the back and lines in the front. Dots at the back and lines in the front. Patient is happy. Patient's pain is gone, and we are gone. So now, if I bring you to the case that we had seen in the beginning, tell me now, will you do this case without seeing the back tooth? Yes? No? If you still decide to do this case without looking at the back, you are going to invite trouble. So this is the case. There is wear in the front teeth. There is wear in the front teeth. Where do we look? We look at the back. We see a missing tooth here. What do? We see the wear facets. We take the anterior deprogrammer. We first get the centric. Then we do a designing there in the centric. Okay. Then yes, we remove one tooth which is badly decayed. We place an implant there. We prepare a bridge here, and we place some anterior restorations which are not only good looking but in perfect occlusion, right? Not in maximum intercuspation. Our maximum intercuspation is coinciding with centric. So because of this, we have a stable occlusion. We have not done a full mouth rehab for this patient. We have just done some anterior crowns for the front four teeth, but we have done some rehabilitation by doing occlusion, uh, re- by doing some occlusal reshaping in the back teeth, right? That's how you see the beautiful dots in the front and the back. So from this, now we have this. Now I can sleep peacefully at night knowing that she will not come back to me saying that, doc, your expensive, metal free crown has chipped. Okay. This is the sideways. Now let's look at this one last case before we wrap up. Generalized severe sensitivity with persistent, headaches. She had been to many doctors and dentists for a pain in the head. She had been to a neurophysician. She was diagnosed with migraine. She had attrition there. She had been to dentist. She was first told to use senso Sensodent K. Then she shifted to Sensodyne and whatnot. Somebody told her Vantage is the best toothpaste. She tried everything to the point where doctors started to tell her we need to do root canals for your teeth one after the other. You know, you know, I would say luckily she then happened to visit us. Then we did the diagnosis. We checked a bite. We did record the centric. Made the temporaries. Got the occlusion right in that, and then cemented the final restorations, some good looking restorations with some beautiful dots in the front and the back and some lines. And this is how she is, right? And this makes the patient smile, this makes us smile. So, what was the goal of our today's webinar when we started? Well, my goal was not to teach you occlusion, because it's not possible to teach you occlusion in 1 hour. My goal was to create some, awareness that what you can miss out, and what all uh, there are the possibilities in the mouth that can be done when you completely understand occlusion. Secondly was to create an awakening that what harm you can do to the patient if you do not understand the basic principles of occlusion, and yes, to generate some curiosity, that is to learn more about it. Okay, so if you will still go ahead and treat this case by doing composites, and if your answer is no, then I think I have achieved my goal for today's webinar. So to conclude my slide today, you need to invest there in the right learning and the right armamentarium. That's that's all folks today. Thank you for listening. uh, Suppose if you have any more questions or doubts, okay, you can get in touch with me. And now if doctors allow, we can keep the panel open for some questions and answers. Okay.
Yes, sir. Basically, questions are there in the chat box. There are some questions.
Okay, can you please take up the questions, because I can't see the
You can
chat
just click
box.
on the chat. You can just click on the chat.
1 minute, I'll just
Yeah.
try doing that. The chat box is there, visible down. I will stop sharing my screen once, and if I can see the chats. Okay. Please remove the scribbles. Okay.
No,
Oh
no,
God.
just go down. Just go down by 8:53.
Okay. So were the scribbles there throughout the presentation?
No, no, no. It got removed afterwards.
Okay, okay, okay. I'm sorry because like there were a few, there messages. Okay. Definition of CR, most wanted Viva question. Yes, that's right. Uh, so how to decide on the thickness of the deprogrammer? Well, just to make your answer simplified, it just you know needs to minimally keep the posterior teeth out of occlusion. Okay, we have already learned that you can make it close to 20 millimeters thick and still you will be in centric relation, but you do not need to make it 20 millimeter thick and make your life complicated. Keep it of the minimal thickness where you can just cause the disocclusion of your posterior teeth. Now, what material was used for load testing? Well, there was no material used for load testing. What I had used a material uh, was was a bite registration paste. It was by Medicept called as Orange Bite. It is an that's a rubber-based material. You can use a wax too to record the bite, but the load testing is done by the fingers that you need to apply pressure going going towards the joint in the vertical axis. Sir, if completely adhered teeth, if we have to plan to rise the bite, can you recommend any tips for doing it properly? Yes, that I can say is that you will need to learn more, which is not a scope of this lecture. Thank you, sir. Thank you, sir. Thank you. Very useful. It was an insightful session. I'm so glad. I'm so glad that it really helped. Wonderful presentation. Thank you. Is there any method to fabricate? Yes, you can use so suppose you want to make it in white acrylic resin. You can use the chair side cold cure resin. You first need the patient's model, plaster models. You need to apply there some separating media and then mold it out there. Or the second option is to use pattern resin and make it. They are both completely acceptable. Are there any course that you would recommend to learn more? Yes, there are a few. One of them, what you can do is with Dr. Moise Kakiani. He's a wonderful speaker. Else, if you know IDA is conducting a course there at their center, for a couple of days, then I can come down there for for a complete physical course to teach you the techniques of bimanual palpation to record the centering. So any more questions there? I'm there completely open to answering them. You all can even unmute yourself and answer if you all have any questions.
Uh, there are, if there are some questions, please write it on the chat box.
Oh, oh yes, implant occlusion. Yes. Well, you see, there is a big, basically difference there in the implant occlusion as compared to the occlusion when there are teeth. Okay, the most important difference is what number one is that teeth have got proprioception. There are mechanoreceptors there. So the same formula what you have learned for the perfect occlusion today doesn't apply to implant. So that is an entirely different topics. So when we are talking about tooth supported occlusion, this is the formula that I've showed you. When we talk about implant supported, there is going to be a different concept, that they're an implant supported one. Okay, can we get the presentation PPT? I will ask, then that's the idea of this. Okay. Anything else you would like to know or ask?
I think the question answer session has been over now.
Okay.
Rohan sir, there are no more questions, so we like to end.
Right.
From ID and everything, from everybody, I like to thank Rohan sir for a very good webinar. It was interesting and very helpful for the participants. Thank you so much, sir, from ID and from the team.
Uh, I'm glad I could help. And until next time, please continue learning, because this is a topic which will never end. After 15 years of practicing, still I'm learning daily something new. So, good night to all of you all, and see you all soon. Thank you so much.
Thank you so much, sir. All the participants, there is a certification link in the chat box. Please fill the Google form link. Then only you will receive your certificates. Okay. A very good night, everybody.
Good night.
Good night, sir. Good night. Good night, Rohan, sir.
Good night. Good night. Thank you. Thank you.
Thank you so much, sir.
Yeah, pleasure.
For the certificates, please, there is a link of a Google form in the chat box. Please do fill that because I am ending the webinar now. Thank you so much. Good night, everybody.